Hi, welcome to Carolina Breast Friends. Today we are doing a virtual education program. We are talking about triple negative breast cancer updates, research, and treatment. And we are joined by Atrium Health's wonderful doctor, Dr. Tan, who is over the section of breast medical oncology. Among many other accolades that she holds, and I know a lot of our local survivor and thrivers just have the most upward respect for Dr. Tan. So we are so grateful that she is able to join us today to give us some updates on triple negative breast cancer and what's happening in the medical world. So with that, I will turn it over to Dr. Tan.
Thank you, and it's great to be here to share an update on triple negative breast cancer. So I'm going to begin my talk here and start off with reviewing information about early triple negative breast cancer. And this can often be aggressive, but it can be treated effectively. It's usually treated with some combination of surgery, radiation therapy, plus minus. It depends on the individual situation. We know chemotherapy works well in triple negative breast cancer, and some people with early triple negative breast cancer may have cancer remaining in their breast after receiving neoadjuvant chemotherapy. So that's treatment given before surgery. And in this case, there's a chemotherapy drug called capecitabine that has been shown to lower the risk of the cancer coming back and helping patients live longer. There's also been several breakthroughs for the treatment of early triple negative breast cancer. And when you may be familiar, one class of drugs called immunotherapy, drugs that target the immune system, the one particular agent is called pembrolizumab. And there's also PARP inhibitor therapy. The PARP stands for uh, long several names chained together, but it's poly ADP ribose polymerase. And these drugs target DNA repair, but it's only used as part of treatment for some people who have a genetic inherited gene mutation in BRCA1 or BRCA2. And one example of this drug that can be used in this setting is called olaparib, and this is a oral medication. So I want to just share with you some important studies that have formed the way we currently treat patients and considered standard of care. The slide may look a little complicated, but I did want to walk you through it. There's a trial that we referred to Keynote 522. This was a large phase 3 clinical trial, which is the gold standard and what the FDA usually reviews, that then leads often to how drugs get approved to treat breast cancer as well as other cancers. But in this particular large international study, uh, the patients that were enrolled had newly diagnosed triple negative breast cancer, but these were early stage triple negative breast cancer patients. And the question here was to see and evaluate what's the role of pembrolizumab when added to chemotherapy before surgery. So again, giving it what we call neoadjuvant. And so what you can see here is that patients were randomized in a 2-to-1 fashion. Twice as many patients received getting pembrolizumab with the chemotherapy compared to not getting the pembrolizumab, and then went on to surgery. And then after surgery, the patients that were randomized to get the pembrolizumab with the chemotherapy were then able to continue additional exposure or additional treatment with pembrolizumab. And the trial looked at what we call pathologic complete response rate, meaning the percent of patients that were able to be, were at when the tumor is removed and looking at the surgical specimen, if there was clearance, if you will, of cancer in the actual breast tissue and nodes. They also looked to see if there was a difference in terms of patients um, not recurring, and also in terms of with the addition of the pembrolizumab, patients living longer. And so, excuse me. So this was a positive study, and so this puts it in, shows you the results, where the addition of pembrolizumab to neoadjuvant chemotherapy, and then with patients getting surgery, then followed by adjuvant pembrolizumab, it did result in improvement, what we call improvement in event-free survival when they look at this in 3 years. So 84.5% with the addition of the pembrolizumab compared to 76.8%. So what I want you to take away from this is that the addition of pembrolizumab, this immunotherapy treatment, to our standard of giving chemotherapy in the neoadjuvant setting for patients that have stage 2 to 3 triple negative breast cancer, and then we follow it with additional pembrolizumab after surgery, had improved outcome. And again, there's certain criteria. It has to be certain tumor size. That's what outlined in that bullet. So tumor size that's greater than 1 centimeter, but less than or equal to 2 centimeter with nodes involved, or a tumor that's greater than 2 centimeters, whether or not there's nodal involvement or not. There's a marker called PDL1, programmed death receptor ligand 1, and this is not necessarily needed or needs to be checked in the tumor before receiving it in this setting. This is different, though, in the metastatic setting, which I'll address later. There are side effects from adding pembrolizumab to chemotherapy in the neoadjuvant setting, but for the most part, the side effects are low grade and manageable. And so the takeaway point here is that the addition of the pembrolizumab to chemotherapy when given before surgery or neoadjuvantly does improve pathologic complete response, event-free survival, and overall survival. And subsequently, it was approved by the FDA and is considered standard of care, for those patients who meet the criteria as listed here. I'm going to now talk and switch and tell you about PARP inhibitors. So PARP is an enzyme that helps repair DNA damage. These agents try to keep cancer cells from repairing tumor DNA that's damaged. Now, PARP inhibitors also have side effects, but all in all, these drugs are often easier to tolerate than our classic chemotherapy drugs. But these drugs only work in people who have the BRCA1 or BRCA2 inherited gene mutation. And we know that breast cancers that have the BRCA1 or 2 mutation have problems repairing DNA. And so these breast cancers then are sensitive to the DNA damage that's caused by the PARP inhibitors. So treating a breast cancer that has this mutation with a PARP inhibitor makes it harder for the breast cancer to repair itself, and that's how that leads to the tumor cell dying. So that's the mechanism of action. So I think it's an important, important message to relate to you. Now the trial, again, these schemas are often busy to the eye, but these are the types of slides that get shown at our national meetings when important data gets presented. But what I just want you to understand or focus on is patients for this Olympia trial were early stage triple negative breast cancer patients. They also had hormone receptor positive patients too, but I just want you to, since this is a talk on triple negative breast cancer, but these were basically early stage triple negative breast cancer patients that possessed a BRCA mutation. And if they received chemotherapy up front, meaning neoadjuvantly, they participated on trial, they then could receive the olaparib or PARP inhibitor for a whole year versus not getting it. And if they happen to have had surgery first, and then were receiving chemotherapy, after surgery, what we call adjuvant, though there are certain triple negative breast cancer patients that were also eligible. Okay, so that's all this slide is saying. The takeaway points of this is based on the results of that trial, there was an improvement in the what we call the endpoint of disease-free survival, meaning less patients had the disease come back while being on this adjuvant olaparib PARP inhibitor and also lived longer. So again, there are certain stipulations to receive olaparib. One I'll point out is if a triple negative breast cancer patient who got neoadjuvant chemotherapy and then after surgery, there was still some residual or leftover disease, they would be candidates to receive this oral medication for 1 year. So again, the results of the Keynote 522 study, the results of this Olympia trial have really changed the standard of care, which is why I'm highlighting that for you. And so just to kind of recap a little bit here, in terms of the role of immunotherapy in triple negative breast cancer, the combination of pembrolizumab and chemotherapy is a standard of care for neoadjuvant treatment of stage 2 to 3 triple negative breast cancers. But there's a caveat. There are some side effects that are associated with giving immunotherapy with chemotherapy. And so there is a critical need, I feel, that we really need to develop biomarkers, whether it's in the tissue or blood, that's going to predict for who will really benefit from getting the combination of chemotherapy and immunotherapy, because there are side effects, when we're using the combination. I think there are people who may not need the immunotherapy and could do just as well with chemotherapy alone. But we don't have we can't tease that out with the current data that we have. So future work really needs to be done so that we can understand if we can simplify our treatment, but yet achieve the same outcomes that I've shown you. I did want to mention that the way we move the field forward and find better treatments for patients so patients live longer is through clinical trials. And a lot of the clinical trials and research that are done have paved the way for our treatment of patients currently. This is a clinical trial called Optum-ICE. I think there is some merit to having these acronyms for trials, because I think researchers as well as patients can also remember it, because some of it can make it more memorable. But as I was saying before about trying to tease out who are the patients who really benefit from immunotherapy, what this trial is trying to answer the question is, if a patient achieves a pathologic complete response after they receive neoadjuvant chemotherapy, meaning there's no tumor in the breast or nodes, is there benefit, or could things be unchanged if they didn't receive the pembrolizumab? So what in this trial is, those patients, again, who have received pathologic complete response will then get randomized to continue on with pembrolizumab, which would be our standard approach. But we really want to look at the question is, because they have done well with the neoadjuvant treatment they received, maybe they don't need the pembrolizumab and then be subjected to all the side effects. So we are in the current process of opening this trial at our center. So now I'm going to switch over and talk about treatment of metastatic triple negative breast cancer. So this is breast cancer that's spread to other organs and is beyond the breast and nodes. And this, again, is often treated with chemotherapy. Some people with metastatic triple negative breast cancer may also get other drug therapies in addition to chemotherapy. And this is where that marker that I spoke to you earlier about PD-L1 stands for programmed death receptor ligand 1. So in the metastatic setting, it's been shown that you need the marker to benefit from getting the immunotherapy, where that's not the case for early stage triple negative breast cancer, which is why we don't check it, or it's not necessary to know the status. But in the advanced setting, it is. And so pembrolizumab is the agent that's currently approved to treat metastatic triple negative breast cancer if the tumor possesses that marker of PD-L1. And how these drugs works is they take the break off natural factors in our body that limit how the immune system can control the tumor cells. And you may wonder, well, what happens to the metastatic triple negative breast cancer tumors that do not have the PD-L1 marker on them? There's still a whole host of treatments that we can use, and they're listed on this slide, and they range from using chemotherapy as a single agent. There's taxanes. There's a class of drugs called anthracycline. This is where doxorubicin falls in, capecitabine, and so forth. There may be situations where one may need to use two agents or two chemotherapy agents. So I've listed some combinations there. Paclitaxel and carboplatin is a very common one. CMF, cyclophosphamide, methotrexate, and 5-fluorouracil is one that was commonly used before the taxanes were available to us, and sometimes we can use that in certain situations. So there are plenty of agents here that are in the armamentarium to be used to treat metastatic triple-negative breast cancer. There's been a lot of paradigm-shifting breakthroughs, and so I think it is a very exciting time to see that how the field has progressed, how the treatment landscape has changed from just having chemotherapy available. As I mentioned, for the early stage setting where PARP inhibitors are available to give for early stage triple negative breast cancer, but this is also available to give to triple negative breast cancers in the metastatic setting that possess the BRCA1 and BRCA2 mutation. Pembrolizumab with chemotherapy is available to us to use first line for those tumors that are PD-L1 positive. There's a scoring system. The CPS is called combined positive score. So it has to be a certain number, and this is often will be viewed on the path report. So it has to be 10 or greater. And there's a new kid on the block called sacituzumab govitecan. It's an antibody drug conjugate, and this is available to use after first-line therapy, so using it second-line therapy and afterwards. So just want to go over some important points about some of these new therapies. So I mentioned sacituzumab govitecan. This is a TROP2 antibody drug conjugate therapy. Metastatic triple-negative cells tend to have higher levels of this protein called TROP2 compared to other breast cancers. And sacituzumab govitecan, the trade name there is Trodelvy, is what we call an antibody drug conjugate or TROP2 antibody drug conjugate, and I'll show you the structure shortly. It combines the TROP2 antibody drug with a chemotherapy called irinotecan. Interestingly, irinotecan is not one of those classic chemotherapy agents that we use to treat breast cancer. It's commonly used in colon cancer. But this novel concoction of an antibody drug conjugate where it allows targeted delivery of the irinotecan to cancer cells with TROP2 has been very effective. I just want to bring up PARP inhibitor therapy too, and just to remind you about how this particular approach is specific to breast cancers that have BRCA1 or BRCA2 gene mutations, whereas olaparib is only approved in the early stage triple negative breast cancer setting. In the metastatic breast cancer setting, in addition to olaparib, we also can prescribe talazoparib. So they're both oral PARP inhibitor drugs. And then HER2-low therapy is also a novel or a different strategy too. There are some triple-negative breast cancers that can be classified or labeled as HER2-low. And for those types of breast cancers, there's an antibody drug conjugate called trastuzumab deruxtecan. The trade name of that is Enhertu. And so that's used also to treat some metastatic breast cancers that have low but detectable levels of HER2 expression. So when I'm faced with a patient that has metastatic triple-negative breast cancer, there are certain markers that I'd want to know so that I can treat the patient effectively. So one is that BRCA1/2 germline status. That's often diagnosed with sending a blood sample. I'd also want to know if the tumor expresses the PD-L1. And then there may be other targets that we can find in the tumor. And I will often send what's called next generation sequencing, and that's on the tumor, although it can be sent on the blood. There may be some rare targets that can be found, which I listed on the slide, some targets called NTRK fusion, high tumor mutational burden, MSIH or dMMR. But the thing about these particular markers is they're very rare and very hard to find. But I think it's still worth sending because if that is detectable, there are other options for treatment. So Keynote 355, again, another slide that's showing you a study design. But basically what I want you to take away from this is these patients had metastatic triple negative breast cancer. They've not been treated for their disease, and they were receiving this type of therapy as their first time regimen. And the patients that participated in this trial were randomized to receive pembrolizumab and chemotherapy, or at the time, what was the standard was chemotherapy alone. And this is a typical what we call Kaplan-Meier curve, looking at overall survival or how long patients live receiving both treatments. And so what you can see here, represented in the green, so the group of patients that got pembrolizumab and chemotherapy represented here in the green, and they benefited from receiving the combination, because you can see here that the overall survival is 23 months compared that those did not receive the pembrolizumab. So this then has now become our standard of care and also approved by the FDA, seeing this this 7-month difference. So I want to just also, I was going to talk to you or show you about these antibody drug conjugates. These have really made a splash in terms of treatment of patients with cancer. And in this particular case, I'm just focusing on triple negative breast cancer. It is composed, so this is a Y-shaped kind of structure, but there's 3 parts to it. One is the antibody part, the linker. So this is the antibody part, which is that Y-shaped structure. The linker is here in yellow, and then the drug is represented with this red circle. And so what happens is there's this portion here where there's, like this is a V shape. This is where it binds the target. Okay, so this can be engineered. But what's neat about it is this linker molecule, if you will, that's joined to the chemotherapy. So that way, this antibody drug conjugate can go to the target, and then there's a process where then the chemotherapy can get internalized and then released. So you can view it as targeted delivery of the chemotherapy. And there's several agents that are available. The one that I want to remind you or highlight again is sacituzumab govitecan, which is this TROP2 antibody drug conjugate. So again, you can recognize here this, the Y-shaped antibody, the linker, and then the green ball here would represent the chemotherapy agent, which in this case is irinotecan. So every antibody drug conjugate is going to be formulated a different way, but this is the one that's currently approved to use as a second-line therapy for patients with metastatic triple-negative breast cancer. And that clinical trial was called ASCENT. And again, these are large phase 3 randomized trials where you're looking, where the goal is to show improvement, both in activity, in patients living longer, in patients being free of disease, or or the disease not getting larger. And so this trial randomized patients with metastatic triple-negative breast cancer who had received at least one prior line of therapy to this antibody drug conjugate called sacituzumab govitecan, or treatments physician's choice, which could include, for example, a taxane or other agents such as that. And the take-home message here is that there was improvement in terms of a higher response rate, longer progression-free survival, and longer overall survival. Patients who are living longer receiving this. So this then has now, this is approved to be used after first-line treatment. Now, as with other agents, there are side effects. So with this particular drug, it does include a low white blood cell count, or neutropenia, and then diarrhea is common. But these are all manageable side effects, and they can be managed with either reducing the dose of the sacituzumab govitecan or adding potentially agents such as growth factors or injections under the skin to boost the white blood cell count, and also medications such as Imodium to help deal with the diarrhea. The other trial that I wanted to, or data set that I just wanted to share with you is called Destiny Breast 04. And so this was a randomized phase 3 study looking at trastuzumab deruxtecan, or it's commonly called TDXD. And again, you can see this similar theme here, this kind of, this Y-shaped structure. So this is the antibody, and it binds to the HER2 receptor, actually. You see this cleavable linker, you see the ball shape, which represents the cytotoxic agent or the chemotherapy, which in this case is a topoisomerase 1 inhibitor. And so these are HER2 low patients. So these are patients where there's this low level of HER2 expression, and there are some triple negative breast cancer patients that fall in this category. In the trial, though, there was you could say that it was a very small amount. There was only 60 patients that met this criteria. But nevertheless, the trial looked at randomizing patients to this antibody drug conjugate TDXD or chemotherapy of choice. And what they found was that this trastuzumab deruxtecan was an active drug, and it does provide a new treatment option for those patients that meet that criteria for being HER2 low. And what's that criteria? So it's when I look at a path report, I'm looking at the expression of HER2 and how much is there. And so if the tumor expresses a level of 1+ of the HER2 or 2+, and then there's something called FISH, another testing that's called fluorescent in situ hybridization. So if that's negative when the immunohistochemistry marker is 2+, that would meet criteria for being HER2 low and then being able to be a candidate to get TDXD. So it's a small portion, about 33% of triple negative breast cancers would meet this criteria. And so this trial showed that there was a gain in 6 months of overall survival. And again, side effects are important to highlight. And with this particular drug, there is a unique side effect that we're all providers, and we counsel patients who are going to receive this agent, that you can develop a situation where there can be some inflammation of the lungs. And this can manifest itself as increased cough or shortness of breath. It's very important that this is detected early because it can progress and patients can get into some respiratory, serious respiratory distress. And the treatment is with steroids. And it's usually reversible, but the key is to identify it early. Now, we had our American Society of Clinical Oncology meeting in June, and there was several potentially practice-changing data. So I just want to highlight one for you as it relates to triple-negative breast cancer and metastatic triple-negative breast cancer, and this occurred in the first-line setting, where I've told you that our standard of care, based on Keynote 355, is to, one of the Keynote 355, giving chemotherapy with pembrolizumab as long as the tumor is PD-L1 positive. So with at our recent meeting where thousands of oncologists gather from all over the world to hear the latest data, this study was presented where it was looking to move the sacituzumab govitecan antibody drug conjugate earlier, so to give it to those metastatic triple-negative breast cancers that had not received any treatment for their disease, but combine it with the immunotherapy pembrolizumab. And so the thought here was, can we make more improvements, right? We know the sacituzumab govitecan is effective as second-line therapy, But with combining it with immunotherapy, could it work better than just chemotherapy and pembrolizumab together? And I already showed you the antibody drug conjugate structure. So this study was conducted. It was called ASCENTO 4. And just to highlight again, so these are patients with metastatic triple negative breast cancer that had not received prior therapy at all in the metastatic setting. Their tumors did express that PD-L1 protein, and the patients were randomized to receive the sacituzumab govitecan antibody drug conjugate with the immunotherapy agent pembrolizumab, or what's considered our standard approach, chemotherapy with pembrolizumab. And what were the results of the study? So this showed that this combination of sacituzumab and govitecan with the pembrolizumab did result in participants living longer without their cancer getting worse. There was more shrinkage of their tumors. You can see here about 60% versus 53% who received chemotherapy and pembrolizumab. And they were also likely to have their tumor stay smaller for longer, about 7.3 months longer. So certainly this was very positive data. In terms of side effects or what we call adverse events, we're kind of in the clinical trial lingo. But I mentioned to you before that sacituzumab govitecan alone does result in low levels of the white count, so the white count going down, and also diarrhea. So that was also prevalent in the study, and again, something that patients need counseling on, and providers need to provide that education, and providers also need to know how to manage this so that it doesn't impact a patient's quality of life in a big way. So the concluding remarks from this trial was that there was benefit to combining pembrolizumab with sacituzumab govitecan in this first-line setting for metastatic triple-negative breast cancer patients that do express that protein, that PD-L1. So currently, the data is fresh, like I said, just released. And so what needs to happen now is the regulatory agencies will review it, and we will see if it will then become available and get FDA approved. So I wanted to just summarize the role of clinical trials, because as you can see, based on all the data I presented to you, these are designed to build on the current standard of care. There's benefit to doing this. Really, without these trials, we can't develop better treatments for our patients for the future. There's different phases of trials. The ones I showed to you are phase 3 trials. So these are trials. I hope you notice the theme of how this new treatment compares with the current standard treatment. There are earlier types of trials called phase 1 and 2. Phase 1 trials determine what dose is safe and maybe testing new drugs or new combinations of old drugs. We have a phase 1 program here where we are conducting these so-called phase 1 studies. And some of them are really novel agents. They could be agents that are first in human. So I think we're lucky and fortunate that we can offer these types of early type trials to our community. And then phase 2 trials are much smaller trials, and they're looking to see if the drug or intervention has effect on the cancer. So there are pros and cons of participating in a trial, but I think the pros outnumber the cons. I'm a clinical researcher, so I do admit I will be biased here, but I do feel that the benefits to participating in a trial is access to newer promising therapies before they're approved. I hope I've been successful to show you that does help to move the field forward. Further the knowledge base that helps us improve care for breast cancer patients and potentially help future cancer patients. But I also want to be transparent. There are cons, and there's no guarantee that the trial treatment is better. So there is a chance that one is taking there. There may be some unexpected side effects, and there is additional time that is needed for someone who does participate on a study. For example, additional visits, and there's more monitoring. There could be asks of additional blood draws because the sponsor of the study may want to check the level of the drug in the blood, and there also may be some tumor biopsies that may be asked. So what clinical trials are available at Levine for triple negative breast cancer? I just wanted to highlight that for you in case any of you in the audience think you might be eligible, or you may have people that you know. So this study called Exact ctDNA 003, I think is a quite unique study. There's been a lot of excitement about what's called circulating tumor DNA or liquid biopsies, and the role. And I think there still needs to be a lot more research to validate whether there's a correlation with detecting the ctDNA and reoccurrence of cancer. And that's what this trial is trying to answer. So this particular study is eligible for triple negative breast cancer patients who are getting neoadjuvant treatment. And all that's needed is blood draws at different time points. So you can see here represented by the purple tear drop, if you will. Blood is acquired at baseline before neoadjuvant treatment, during neoadjuvant treatment, after post-surgery, and then other serial collections post-surgery, up to 5 years. And so the goal of this is to do a correlation. If there is a positive ctDNA test, is it actually correlating with recurrence, meaning detection of cancer or presence of cancer on scans? So I do think this is going to help us add to the current data that we know about what's the role of ctDNA. There's another interesting study that my colleague, Dr. Hickey, is in charge of, and this is asking the question of, can looking at certain markers in the stool predict how well someone will do on immunotherapy and chemotherapy? So again, this is a trial that is enrolling triple negative breast cancer patients receiving chemotherapy and immunotherapy as neoadjuvant treatment, and then collecting blood and stool to assess certain markers, and then do correlation with clinical outcome. And then another study that is just about to open, we're close, but it's looking at a different type of antibody drug conjugate than sacituzumab govitecan. This one's called MK-2870. So those patients that do not achieve a pathologic complete response after getting neoadjuvant chemotherapy and immunotherapy will get randomized to pembrolizumab and then this newer drug called MK-2870 versus staying on pembrolizumab or capecitabine. And again, seeing if we can build upon our current standard of care and do better than what we're doing now. And then a homegrown trial is actually one that I developed, and this is looking at the role of what we call a cyclin-dependent kinase 4/6 inhibitor. It's called trilaciclib, and this drug is often given before chemotherapy to block a cell as it goes through its cell cycle. The cell cycle is illustrated here. It goes through these different phases called G1, S, G2, M phase. And so this drug is an interesting drug. It's actually approved for small cell lung cancer as what we call a myeloprotective agent. So it's been shown to help minimize the side effects with certain chemotherapy agents that can cause the white count to go down, the platelets to go down too. But what we're looking at in this particular trial that we developed, so this is what we call actually a phase 2 clinical trial. We're looking for patients that have metastatic triple negative breast cancer and they may be maybe the plan is to give them pembrolizumab, gemcitabine, and carboplatin, but we're adding the trilaciclib to see if they're, if we could do better than just giving that triplet regimen alone. So this is a trial that we developed, here at Levine, and are currently recruiting patients. So in conclusion, I want you to take away that triple negative breast cancer, there's heterogeneity. I mean, not all triple negative breast cancer patients, it's not a one size fits all strategy. We need different strategies to treat, develop treatment plans. And very important to have the markers available to know how to individualize our treatment, for our patients in the metastatic setting. And that is to know what the status of the PD-L1 is in the tumor tissue, but also to know if a patient's harboring a germline BRCA1 or 2 mutation. And as I've shown you, several advances have been made in terms of drug development, the recognition that a subset of these triple negative breast cancers have the PD-L1 protein and benefit from getting immunotherapy. We've identified other novel targets like the PARP enzyme, and therefore have the PARP inhibitors available. TROP2, we've learned, is a target that's present, although it's not required to test because several TNBC patients have that already on their tumor, and so we have sacituzumab govitecan. And then the small subset of patients that have kind of low levels of HER2, we're able to give trastuzumab deruxtecan. So all of these have led to improved outcomes for patients with metastatic triple negative breast cancer. And triple negative breast cancer, as was mentioned, is a focus of my clinical research, and I really want to improve and meet the needs. And I've learned over the years, does it require intense and prompt treatment with multidisciplinary experts, as well as evaluation of genetics and wellness, wellness support services. And studies show that patients with triple negative breast cancer have unique needs, and they do require more customized education and information support. And so we're trying to do that here. And there is, as with other cancers too, but it comes with high levels of anxiety, fear, and worry during, and post treatment. And so we have to be able to minimize this. And so, I think what we offer here is that we have a great team of physicians and also researchers to work together so that we can bring the latest advances in triple negative breast cancer care to our clinics, particularly in the form of clinical trials and these cutting edge therapies. And the hope is that we also have we have a network of support services to care for triple negative breast cancer patients and families, and also with the focus of having opportunities for patients with TNBC to take advantage of any research opportunities, so that patients can potentially benefit from receiving those therapies, but also pay it forward, so that future TNBC patients can also benefit from receiving those treatments. So that's the end. I'm going to try to come out of this.
Just thank you so much, Dr. Tan, for this presentation. It was very informative. I know we've got a lot of questions that people want to ask. So at this time, I will stop the recording.